Welcome to The Explainer. Today we're diving deep into the meticulous protocols for preventing infections in eye surgery. This is a field where every tiny detail is absolutely critical to success. And this quote really just says it all, doesn't it? When you're working on a scale this small, stopping an infection before it starts isn't just a detail. It's the whole ball game. It's what protects a patient's vision for life. Okay, let's jump right in. We'll start by locking down the fundamental goal here, because every single decision we're about to discuss all points back to this one core objective. The goal is simple, and it's completely non-negotiable. We have to stop surgical site infections, especially the kind of devastating infections that can happen inside the eye. The whole strategy is designed to kill the most likely culprits, usually bacteria that are already living on the patient's own eye, like Staph aureus. Now, let's get into the foundational rules that apply pretty much across the board. We're talking about two of the most critical variables: when you give the antibiotic and how much you give. You know, timing is absolutely everything. The idea is to have the antibiotic concentration at its peak inside the eye at the exact moment the surgeon makes the first cut. For most drugs, that means getting it in within that 60-minute window. But for others, like vancomycin, you need a little more lead time. So you might think one dose is all it takes, right? And usually it is. But there are a couple of key exceptions. If a surgery is dragging on for more than 4 hours, or if there's major blood loss, you have to redose. You have to, because otherwise the antibiotic levels can drop too low to be effective. So, with those core principles in our back pocket, let's see how they get applied in different situations. We'll start at the front of the eye, looking at surgeries on the cornea, lens, and for glaucoma. Now, this is where it gets really interesting. Look at how the pre-op and intra-op steps are pretty much the same, but the post-op care is completely tailored. A lens operation might only need 2 weeks of drops, while a corneal transplant needs 3 months. That difference is all about the level of surgical trauma and the risk of inflammation, which directly ties to the risk of infection. Okay, let's shift our focus from the front of the eye to the back. We're going to review the protocol for procedures like vitrectomy, which involve a whole different part of the eye's anatomy. Now, here's the key difference to notice. For these post-op surgeries, the duration of post-op treatment isn't a fixed calendar date. It's actually guided by how the patient is recovering. This allows for a much more flexible, individualized approach based on what the surgeon is seeing. All right, now for a really critical curveball. What happens when a patient has a history of herpes simplex virus, or HSV-1, affecting their eye? Well, this completely changes the game plan. We have to add a whole new layer of protection. So you see, the strategy has to pivot. We're no longer just defending against bacteria. We now have to add a strong antiviral defense too. Why? Because the stress of surgery and the steroids used afterward are perfect triggers to wake up that dormant virus, which can be absolutely devastating. 9 to 12 months. Let that sink in for a moment. For someone with an HSV-1 history who needs a corneal transplant, that's the minimum amount of time their eye has to be completely disease-free before a surgeon will even consider operating. It's a mandatory waiting period. But now compare that to other types of eye surgery, like for a lens or glaucoma. Here, the required disease-free period is shorter, just 3 months. It's still a crucial waiting period, but it reflects a calculated approach to risk. The danger is still there, but it's considered lower when you're not transplanting a new cornea. Okay, theory is one thing, but let's put all this knowledge into action. We're going to walk through a few clinical scenarios to really see how these protocols work in the real world. All right, first up, a pretty standard case. A patient is coming in for a lens operation. No tricky history, no HSV-1. What's the complete game plan? This is your classic standard of care. You start with povidone iodine to clean the surface, use cefuroxime inside the eye to target those common bacteria, and then you send the patient home with Tobradex drops for at least 2 weeks to handle both infection risk and inflammation. Okay, case number 2, and this is our special consideration. You have a patient who needs a corneal transplant, but they have a history of recurrent HSV-1 infections in that eye. What are the absolute must-do additions to the protocol? So the critical additions here are twofold. First,
You absolutely enforce that 9 to 12-month waiting period. It's not optional. Second, you start them on an oral antiviral drug before the surgery. And, this is key, you continue that antiviral coverage for the entire time they are on corticosteroid drops.
And for our final case, let's look at a posterior segment surgery. It's a vitrectomy, but it's expected to be a long one, over 4 hours. How do you adapt the protocol for that? In this case, perfectly illustrates that foundational principle we covered earlier. Because the surgery is so long, you have to give a second dose of the antibiotic right there in the middle of the procedure to make sure the drug levels in the eye stay high enough to be protective. The pre- and post-op care remains the same, but that intra-op redosing is crucial. And all of this brings us to a final, really important question. The protocols we've just reviewed are incredibly effective. They are literally sight-saving, but they're designed based on the bacteria we're fighting today. What happens when those microbes evolve and develop resistance? It means these protocols can't be set in stone. They demand our constant attention and willingness to adapt to make sure we can keep protecting our patients' vision tomorrow.